Hello and welcome to the first edition of the Alliance Transplant C-Suite Webisode program. This edition focuses on provider profitability and reimbursement in transplantation. We're pleased to be joined by Andrea Teachin of St. Barnabas Hospital in Livingston, New Jersey. Andrea has been the Director of Transplant Data and Finance since 1999 and has managed all transplant finance, data, and quality activities, including financial and operational reports, billing, regulatory compliance, contracting, budget preparation, and research funding. Andrea is also quite active in the national transplant community. She's a founding member and continues to serve on both the National Kidney Registry Finance Board and the UNOS Kidney Paired Donation Financial Subcommittee. She's presently serving on the AFDT Living Donor Education Planning Committee, the UNOS Fiscal Impact Committee, the Alliance Faculty Planning and Leadership Committees, as well as the AST Living Donor COP Finance Work Group. She's been an adjunct professor at Caldwell University since 2002 and teaches accounting, finance, and healthcare administration in the School of Business. Andrea, we're pleased to have you, and I'll now hand it over to you for the rest of the program.
Thanks, Corey. In this webisode, we're going to talk about provider profitability and reimbursement in transplantation. There are various staffing models that can exist for providers at transplant centers. Providers, including physicians, surgeons, and advanced practice nurses, can be employed by a facility in a private practice group or affiliated with a medical school or academic institution. Each of these arrangements can be complex and can sometimes challenge revenue capture and realization for services provided by the provider. This webisode will describe each structure and provide general information on how providers can be reimbursed for transplant services throughout the phases of transplantation. With this array of provider model options, there can be a tremendous variation in transplant center structure and provider agreements, which can impact transplant physicians, surgeons, and advanced practitioners. Each model, while unique, must seek to maximize profitability and reimbursement, either through cost capture or direct billing. The goal is to maximize revenue received for services provided and to do so correctly and compliantly. First, let's describe the general mechanisms for provider reimbursement. While the organ acquisition method, the cost of provider care for pre-transplant services for the recipient and for the donor is placed on the facility's Medicare cost report. This method allows for both the provider to receive credit for patient services provided and for the facility to capture the cost for these services, which are then reimbursed through the Medicare cost report. This method also allows facilities the ability to capture provider costs for any pre-transplant administrative time. This non-billable time is often considered to be non-revenue producing, but for activities directly related to pre-transplant services, these costs can be reimbursed through the Medicare cost report using the organ acquisition method. Here's an example of how a provider payment is made through organ acquisition, which is the method frequently used for patients who are Medicare beneficiaries that are being evaluated for a transplant. A patient is seen for outpatient pre-transplant evaluation by a provider. The provider then furnishes a claim form or bill, for example, a HCFA 1500, for the level of service provided to the patient to the transplant facility. The facility reimburses provider at agreed upon rate according to the CMS allowable rules. Lastly, the facility captures the cost of the provider service for their Medicare cost report filing. Another mechanism for provider billing is called third-party billing, also known as direct billing. With a third-party billing method, provider charges are billed directly to a patient's insurance company for reimbursement. This method may be used for patients who are being evaluated for a transplant who have commercial insurance coverage. The transplant facility may not be party to this transaction if the provider directly bills the patient's insurance company. With third-party billing, the provider is directly reimbursed by the insurer. The rate of reimbursement would be dependent upon the agreement between the provider and the insurance company. Direct billing may also result in the patient's responsibility for some portion of the provider's reimbursement, as per the patient's insurance plan, in the form of a copay, coinsurance, or deductible. It should be noted that providers may also be reimbursed through global agreements. With a global agreement, the insurance company may pay the transplant facility a lump sum for all phases of transplant care for the recipient and donor providers, otherwise known as a global payment. This global payment can include both facility and provider fees from the point of patient referral for transplant to post-transplant care. Under these circumstances, the provider may be directed to bill the transplant facility and will be paid by the transplant facility for services provided at an agreed-upon rate. Next, let's review the phases of transplantation and describe how provider services are reimbursed throughout these phases. The pre-transplant phase would include provider services from the point of referral until the date of admission for a transplant or live donation. This phase also includes the cost for testing and assessing the suitability of a candidate for transplant, as well as to determine the suitability of a live donor. It would also include costs for tests for maintenance of a candidate while on the wait list for an organ. Reimbursement for these services can be provided through either the organ acquisition or direct billing as previously described. Provider services could be outpatient or inpatient, again, as long as they are for the purposes of determining suitability of the patient for either a transplant or for donation. For a potential transplant recipient, pre-transplant services would include the provider's initial evaluation of the patient and periodic reevaluation to determine the patient's suitability for listing, as well as continued suitability for transplant while listed and waiting for a transplant. For a potential live donor, these services would include the provider's initial evaluation of the patient and the reevaluation, if applicable, to determine the donor's suitability for donation, as well as continued suitability until the donation occurs. Additional revenue may be captured for provider services in the pre-transplant phase that help to determine and assess a patient's suitability for transplant or donation, but are not direct patient care. Examples of the provider services that can be quantified and captured for reimbursement of the provider can include multidisciplinary team or selection committee review of pre-transplant patients attended by the provider, chart reviews of potential candidates performed by the provider, and also organ offer call. In order to capture provider costs for approved pre-transplant services that are not direct patient care, transplant facilities can use time studies. As described in detail in the Medicare Provider Reimbursement Manual, facilities can use periodic time studies to allocate direct salary and wages to their Medicare cost report. There is a limit to costs allowable for provider time spent for pre-transplant administrative time. CMS limits the allowable costs claimed by a facility under the facility's reasonable cost basis. Regulations state that the cost a facility can recover must be limited to the Medicare's reasonable compensation. The reasonable compensation calculation considers medical specialty and geographic area to determine what the maximum allowable cost will be for each facility. Therefore, it can be different between transplant facilities. The reasonable compensation equivalent rules require that costs be adjusted on a pro rata basis for part-time and more than full-time physicians. Any amounts in excess of the reasonable compensation equivalent are not allowed for capture and reimbursement on or through the organ acquisition. Next, we have the Peri transplant phase. This phase includes provider services from the point of admission for a transplant or live donation until the date of discharge from the hospital. Essentially, it includes the services provided during the patient's inpatient stay. Reimbursement for these services can be provided through either direct billing of the insurance company or through a contractual or global agreement between the insurer and the facility. Provider costs during this phase cannot be charged to organ acquisition. An example of a global agreement between a facility and a provider could be that the facility agrees to pay the provider 100% of the Medicare limiting charge for a service provided, which means that the facility will reimburse the provider at the same rate the provider would be reimbursed if the patient were a Medicare beneficiary. In the post-transplant phase, similar to the peri-transplant phase, provider services from the date of discharge from the hospital for the transplant or donation. Reimbursement for patient care services can be provided through either direct billing or through contractual or global agreement between the insurer and the facility. As described previously, the facility could make an arrangement for the provider if a global payment exists. No post-transplant provider services to either the recipient or the donor should be charged to organ acquisition. Now let's describe the various models in detail. In an employed provider model, providers are fully employed by the transplant facility, and in many cases, the majority of the provider's time is dedicated primarily to transplant services and activities. With an employed provider model, providers are paid a salary by the facility. The facility then bills for patient care services provided to patients either through organ acquisition or third-party billing. Administrative and non-patient care services can be quantified and tracked by time studies, as previously described. In a private practice model, providers are not employed by the transplant facility. A contractual agreement may be executed between the providers and the facility, which outlines what services, both patient and administrative, are to be provided and the billing arrangements for these activities in each phase of transplant. An agreement between the private practice and the facility may include a stipend for a provision of services, rate of reimbursement, and allocation of staff or space to assist in the provision of patient care. In a private practice model, the providers can be compensated in several ways. Providers can either bill the transplant facility directly for patient care services, or providers can direct bill patient insurance companies. As mentioned previously, if the provider bills the transplant facility, the cost of the transplant facility pays the provider can be charged to the organ acquisition, and the facility will recover a portion of that cost through the Medicare cost report. A blended model is a model that may exist at an academic institution or a facility that is affiliated with a medical school or university. This arrangement usually involves faculty appointments for providers. Additionally, contractual agreements may exist between the academic institution or university and the facility, which outlines services provided and the billing arrangements for care provided in each phase of transplant. As with the private practice model, an agreement between the school and the facility may include a stipend for provision of services, rate of reimbursement, and allocation of space or staff to assist in the provision of patient care. Providers affiliated with a blended model can be compensated in several ways. Providers can either bill the transplant facility directly for patient care services or direct bill patient insurance companies. Another methodology for billing may allow the medical school or academic institution to bill the transplant facility or direct bill the patient's insurance on behalf of the provider. As with the previous models, if the transplant facility is billed for the cost for the provider, that cost can be charged to organ acquisition, and the facility will recover a portion of that cost through the Medicare cost report. Now let's summarize the general rules from reimbursement. Regardless of the provider group model, The goal is to ensure that providers are reimbursed for any patient care services that they are providing, as well as any pre-transplant time spent that is non-billable, such as chart reviews, program oversight, and other pre-transplant administrative activities. The ways in which providers can be compensated for services provided, either to the patient for any phase of transplant or for non-billable time spent on pre-transplant services, are by direct billing the patient's insurance, by capturing the direct cost for pre-transplant patient care services through organ acquisition, or by capturing the cost for any non-billable, non-direct patient care services through time studies. It is important to note that non-billable services that are not related to pre-transplant activities are not directly reimbursable through direct billing of a patient's insurance or through the facility's organ acquisition. However, these services may be compensated through the various provider models based on agreements between the provider and the facility. There are several options for reimbursement for non-billable services provided to the facility by the provider. With the employed provider and blended models, ways to be reimbursed may include contractual agreements for protected time, stipends, or a modified RVU structure. An RVU is an acronym for a relative value unit, which is a measure that uses a common scale to determine the resources used to provide a service. With a private practice model, there may be an agreed-upon stipend. Additionally, all models may use a variety or combination of methods to calculate reimbursement to providers for research activities performed. This could include research that is grant-funded, pharmaceutical-sponsored, or provider-initiated. In conclusion, there are a variety of models and relationships that can exist with a transplant facility. Both facilities and providers must ensure compliance with the rules and regulations for both reimbursement and cost reporting. For additional information, please refer to the following list of references and resources.
Thanks so much, Andrea. We certainly appreciate you taking the time to lend your knowledge and expertise for this webisode edition. We want to remind everyone watching that in the future, you can access more Alliance Transplant C-Suite Snapshot webisodes and digital publications on our website at organdonationalliance.org. Thanks for watching, everyone, and we'll see you next time.